So, good afternoon all, no talking. So, today the last class of the enzymes, which will be on clinical enzymology, and we will go through the, as before I already discussed, what are the different things you should learn, objective, what are the there, what you should know, and what are the competencies will be there. So, learner will be able to describe isoenzymes, their properties and clinical usefulness in health and disease, enumerate the enzyme markers in various disease, interpret the laboratory values of enzyme assays in different diagnosis, diseases in diagnosis, prognosis and monitoring, list therapeutic uses of the different enzyme, and describe the enzymatic diagnostic techniques and use of immobilized enzymes. So, now what will be the competency you will be knowing? Observe the estimation of SGOT and SGPT that we will be doing in the practical classes. Practically, we will be demonstrating or understanding the role of the AST and ALT. Describe and explain the basic principles of enzyme activity. Describe and discuss the clinical utility of various serum enzymes as markers of pathological conditions, most important. Discuss the use of enzymes in laboratory investigation, that is enzyme based analysis. This competency you should know. These are all NMC regulations, and these will go unto your PG exam also. This the competency should be there. That means you are competent enough. You know, you should be knowing what are the basic things that are related to these topics and how you can apply to the clinical perspective. Interpret laboratory results of enzyme activities and describe the clinical utility of various enzymes as markers of pathological conditions. So, what are isoenzymes? So, isoenzymes, if you see, they are different forms, physically distinct forms of the same enzyme activity. Different molecular forms of the same enzyme, that is synthesized from various tissues, are known as isoenzymes. So, an isoenzymes will have different components, different functions based on the tissue from where it is released. It will have different subunits and it will have specific functions. Hence, study of isoenzymes is useful for understanding disease of different organs. So, when the subunits are same, it is called a homomultimer, and when it is different, it is a heteromultimer. So, different things, different enzymes, structurally same, structurally different, and their functions are very relevant in the study of the isoenzymes. Also, if you see the genetic aspect, it may be the product of different genes, that is more than one locus, which is known as the true isoenzymes. Examples like the genes that we look at different chromosomes, like salivary and amylase, pancreatic amylase, and in cases they are all different forms are present in the same individual. That is in lactate dehydrogenase, which has 5 isoenzymes and are seen in all persons in the population. So, what are the different forms, structural difference between the different isoenzymes, and also you will be seeing the what are the true isoenzymes and its effects with examples. The same locus of the gene may have different alleles, that is the alternate forms. Such allelic isoenzymes are called the alloenzymes. You should know what are alloenzymes, what are different as holoenzymes, will come slowly one by one. In this case, only one form will form from one individual, but all the different forms will be seen in total population. That means in population the different forms will be found, but in one person or single person will not have all the forms, it will have only one form. For example, there are more than 400 distinct forms of glucose 6-phosphate dehydrogenase or G6PD or GPD have been identified. All of them are produced by the same locus of the X chromosome. Try to understand, G6PD or GPD is very important. So, there are 400 different forms and they are formed from the same locus of the X chromosome. So, that will be totally found in the population, but not in the single individual. That is the key finding or key things you should know. When isoenzymes due to variation of a single locus occurs with appreciable frequency, that if it is seen in more than 1% of the population and there is a variation from the single locus, then it is known as a polymorphism. Try to understand when it is called a polymorphism, when it is called an alloenzyme, and what are the different roles. But then only you will understand when you go for clinically treatment of diseases, then you can only target seeing its nature. Molecular heterogeneity of enzymes are also produced after the protein is synthesized, that is the post translational modification that actually occurs. These are called the isoforms. Example, sialic acid content in the alkaline phosphatase isoenzyme. Different forms of the isoenzymes are formed in the same individual. It is a ALP. So, ALP have a different isoenzymes which are seen in a same individual, but they are from different organs or they have been seen in different places. So, what are the different isoenzymes? In electrophoresis, isoenzymes have different mobility. LDH and CK or CPK, that is creatine phosphate or creatine phosphokinase, can be separated by electrophoresis. Why it is electrophoresis used for separation? Because of the with the different molecular weight. I will show you one picture. With the different molecular weight, you will get different bands which will easily distinguish between the different subunits of the particular enzyme. Heat stability. One of the isoenzyme may be easily denatured by heat. That example is bulb or BALP, bulb or bone alkaline phosphatase. Inhibitors, isoenzyme may be sensitive to a particular type of inhibitor. That is one of the important thing is tartaryl, that is tartarate or tartarate, labile, ACP, acid phosphatase. ACP or acid phosphatase, you can see the effect of the different inhibitor, that is tartaryl labile. Labile means easy movement or flow is smooth in nature, that is the labile part. It will be effect on the tartaric acid or the that is why it is called tartarate. The Km value or substrate specificity may be different for isoenzymes. Example, glucokinase has high Km and hexokinase has low Km for glucose. Already we have discussed so many times, but still you should know what are actual difference and what are the effects. Cofactor requirements may be different for different isoenzymes. Mitochondrial isolated DNA is Na plus dependent and the cytoplasmic is NADP plus dependent. So, one is NAD plus and one is NADP plus. So, when the plus moves, NADPH and NADH. Tissue, its localization may be different for different isoenzymes. H4 form of LDH is present in heart, where M4 variety is present in the skeletal muscle. So, LDH, have you see there are how many subunits will be there? You should know how many subunits. I will show you in the figure. They are present in muscle, heart, and other places. Any other places you know? LDH, lactate dehydrogenase. Huh?
Anaerobic respiration.
No, that is the its function in anaerobic respiration. I want how many types of isoenzymes are there, means what are the different forms of the LDH, that is important for me. Yes, that you should know. Slowly we will come to that. Specific antibodies may identify different types of isoenzymes. CK isoenzymes are separated by antibodies, because antigen antibody reaction enzymes are protein in nature. So, particularly tagging with the enzymes will give you the what type of enzyme is there and how it functions. Lactate dehydrogenase enzyme is a tetramer, that I wanted to know from you. Its tetramer means 4 subunits. Try to remember this example, because when you have to write these isoenzymes you will give, you have to write with an example, and that example should be properly written down with the diagram. I will give you the diagram. But the subunit may be either heart or H for heart or M for muscle, that is a polypeptide chain. So, 5 combinations is possible. H and M chains are possible. These combination you write down H4, H3, M1, H2, M2, H1, M3 and M4. All these 5 forms are seen in all persons. This is the important thing. That means, in a single person all the 5 forms are seen. It is a tetramer, but you can go in a 5 different combinations with H and M. H4, last is M4 and all the 3 combination in between. Understood? This is a very simple way to understand, and you should note it down, you write it down, these are important. but when you see in the lab we see as the total LDH. Lab, when you go for the diagnosis, you see the total LDH until and unless specified. CPK also, CPK is mainly for the cardiac disease, that also 3 forms are there. That is why I am telling the importance. If you see what is happening in the polymorphism, what is happening in the alloenzyme and what is happening in the isoenzymes. Generally isoenzymes maximum part is seen in the, all the forms are seen in the same person. But you have to check which subunit and which form is present in which part of the body, which component it is there. Definitely heart means it will be near the heart. If it is in the muscle or thing, it will be in the muscle part. You cannot mix the things. Dono mixing nahi hoga. So it is specific in that isoenzyme part. So this is how this you should draw. This is how you actually see the isoenzymes of LDH. This you should draw properly. When you write in the exams, you should give it this diagram. So that will make you understand how in the serum protein electrophoresis is separating the different bands or different forms of LDH, what we have discussed till now. And what is the right side? That is the how much proportion it is present, that is called the densitometric analysis of the electrophoretic pattern. Because electrophoresis you give the band, but you have to also show the proportion, how much it is present, that is it is done by the densitometric analysis. So point of application in the negative part and moves to the positive. So what you understand from the point of application, the higher molecular weight will be near the point of application and the lower molecular weight will be moving away from the, this basic concept should be clear and you should not mix. Understood? This diagram you should draw properly, no mistake, because this is important diagram. There should be no mistake in this diagram. So just I have given you one example, you can make other examples, you can take, but so the fundamental concept of this separation is by electrophoresis, the different bands will be separated by this pattern depending upon the molecular weight. Which type of electrophoresis? Serum protein electrophoresis. You didn't understand why?
Yeah, I didn't understand why there's those crests over there.
Crust over there, those are protein. You made a protein to run electrophoresis. Electrophoresis you have studied in the class 12 standard.
Yes.
So protein means albumin alpha 1 alpha 2 beta gamma it moves. So if the protein is the low molecular weight and other things, it will be near the point of application. And with the serum electrophoresis, the basic principle will be there will be a static medium and a buffer will be there. In the buffer, the protein moves in the gel. That will be agarose or different thing. You stay in it and you check the which protein component is present where, and depending upon the molecular weight of the substance, you get these bands and the length.
Yes.
This is actually basic serum protein electrophoresis for separating the enzyme isoenzyme bands of LDH. Understood? When you will do the electrophoresis demonstration, you will understand why these bands are there.
So this graph is
Okay. This graph is actually the representation of what is present, how much. Densitometric.
M4 is lower than H3.
No problem. That is M4 is lower because M4 has not moved. H4 is H4 will be lower than M4. That is about the component, how much it is present, densitometry. Quantity hoga. Yes. Quantity hoga. That's not the molecular weight. Quantity ke kitna quantity hai. That is densitometry analysis. We give the clinically jab results denge how much it is present. That is proportion. Don't mix with the molecular weight. Molecular weight will come in the yes, distance. That is just for seeing, but you need the quantity, no. Suppose somebody has some infection, you go for the electrophoresis. In that infection, which protein is more? Yes, like you got the multiple myeloma, you have the M band. You have to see which M band is where and what is the proportion. That is important. Okay. Next is, this is how actually the formation of isoenzymes lactate dehydrogenase takes place. So, subunit A and subunit B, and this is how formation takes place in the electrophoresis. Simple same thing to make you understand in a more simpler way. Color combination gives how actually it interact and how it should be taken into thing. If you want to sleep, you go out. There are different types of electrophoresis, but here serum protein electrode is enough for you. There is agarose gel, that is SDS page and other things you do, but serum protein normally separates. So, positive and negative, negative is the point of application always, and if you see the protein alpha band how it comes, always albumin, alpha 1, alpha 2, beta, gamma. You know already these things, no? These already you studied in the 12th standard only. This is basic thing of electrophoresis. Albumin, alpha 1, alpha 2, beta, gamma. So, where will be the point of application, near the albumin or near the gamma? Globulin. Yes, because that is heavier than, yes. Understood the concept, heavier, point of application, if it is heavier means it will not move, and the lighter one molecule is there which will be moving till the last. So, that you have to take into effect. And when you go for the densitometric analysis, that actually gives the how much quantity it is present, not upon the molecular weight, how much it is present. So, normal there will be a pattern, abnormal pattern, you compare it, and then you will get how much proportion of the percentage it is there. So, this is actually what we can summarize from one other thing. As all the classes, all the slides whenever is there, I summarize the portion that is you should know. So, this is the table where you should understand what is the basic thing that is happening, that is subunit makeup of the isoenzyme, electrophoretic mobility at pH 8.6, that we check it generally 8.6, alkaline pH 8.6 mobility. Activity at 60 degree centigrade for 30 minutes, that means you see the stability of the enzyme. Then tissue of origin and percentage in serum, that is the mean percentage in serum. You see the mean percentage serum is different. So, some if you want to go that I want to specific that particular, it is less, very difficult to detect in the serum. So, the question always arises is that we do the total LDH in the lab. So, what will happen if we go for the different enzymes, subunits? So, that you should answer back. I want the particular isoenzyme that is present in the muscle, or I want the particular isoenzyme that is the heart. We do the total LDH, no, always. So, that what is the answer you can give, or what is your thought process behind it, that is important. So, H4 is the fastest and M4 is the slowest. This you just draw, and this diagram is the figure, you just not this is the drawing, just take the note on the figure, so that you understand what is applicability. So, applicability tissue of origin is heart, muscle, RBC, brain, leukocytes, liver, skeletal muscle. So, throughout the body different places it is being present and has different actions, that is important. So, which proportion is more? Huh? Where it is present? Next is heart, but heart it is there 30%.
Yes,
So, RBC and brain, the problem is what? It may be present both in brain RBC. If a particular isoenzyme is present in a particular organ or a particular way, easy to detect for its specificity. Otherwise, it will be otherwise it will be, it can be present both in the RBCs and is the brain. It should be specific. Everything is difficult, you have to make it easy for understanding.
every enzyme will have a different inhibitor also.
Hmm?
Every enzyme will have a different inhibitor.
Types of the structure, yes. Inhibitor I give you, how the structure analog will come, how will be there, how will we target. Inhibitors are what? The different drugs that it acts to keep the other things. No? That inhibition part we have studied. So, it should be analog, how the analog is going, where it is acting, how it is stopping the enzymatic activity, is it necessary at all, how long it will. So, M4 form is seen in the skeletal muscle, while H4 is seen in the heart. Normally, HCMS blood is greater than H4, but this pattern is reversed in myocardial infarction, and this is called flip pattern. Very important question. What do you understand by the flip pattern of LDH in myocardial infarction? Question I told now. Now, you write down what we are discussing. Afterwards, whenever it comes, don't tell me that I am not discussing. What do you understand by flip pattern, and how this flip pattern is used to diagnose in myocardial infarction? Flip pattern, you understand. What do you mean by flip pattern?
Generally, the HbA1 is more.
Yes, generally the thing which happens is reversed. LDH level is 100 times more inside the RBC than in plasma, and therefore, minor amount of hemolysis will result in false positive test. Since total LDH is increased in many conditions, LDH is not used as a cardiac marker nowadays. That is the thing I wanted to know from you. Different proportion it is present, hemolysis is more. Myocardial infarction is a very serious condition. Now, if you measure some enzyme that give false positive or something, it will be very difficult for the diagnosis aspect, so what to go for the treatment. So, nowadays it is not used as a marker. So, that is why in the book also they have omitted, they have kept the creatine kinase and the different troponins, they have not kept the LDH. Important question, why LDH is not specifically used as a cardiac marker? What are the drawbacks or the problems with the LDH measurements? Because of its presence in a particular tissues in the RBCs, because there is a chance of giving hemolysis which will result in the false positive. False positive is very dangerous, no, which is not actually happening, it is showing that it is there. So, that is false positive, which thing should be ruled out. Understood?
Sir, is H4 present in red blood cells?
लिखा है ना, जो भी लिखा है it's there in the
H4 is present.
it's लिखा है ना, तो जो भी लिखा है, which form is H4 form is seen in the heart,
Yes, sir.
and normally H3 is blood is greater than H4, but this same thing, it is there, part of the present over there. When if it is present only, then hemolysis will be there. We are interested in false positive reactions. We are because we have to rule out that any diagnosis should be not going in a wrong way. Giving a wrong diagnosis by the enzymatic levels will create lot of unnecessary hazards, and that to myocardial infarction, which is very serious, which comes to the trauma and emergency and other things, does not give you much time for diagnosis. Plasma contain many functional enzymes which are actively secreted in plasma, for example, enzymes of blood coagulation pathway. On the other hand, there are few non-functional enzymes in the plasma which are coming out from the cells of various tissues due to normal wear and tear. Their normal levels in blood are very low, but are drastically increased during cell death, that is in necrosis or different diseases. Therefore, assays of these enzymes are useful in diagnosis of disease, very important. What are the different, which are functional enzymes or non-functional enzymes? Your work is to find out the difference between the functional enzymes and non-functional enzymes, their activity, examples, and role in clinical decisions. That is your work. Understood? Functional enzymes and non-functional enzymes, what are their role, their functions, examples, and the clinical utility. Cell death are two types. One is programmed cell death, that is called the apoptosis, and this is the normal cell death that will be during the disease or other condition, that is the necrosis. So, there is a difference between necrosis and apoptosis. This will be used in necrotic conditions, not in apoptotic conditions. Apoptotic conditions things will be different, that is programmed cell death. So, what you can do is that we can check many of the isoenzymes as a biomarker. So, biomarker is defined as one of the naturally occurring molecule gene or characteristics by which a pathological process can be identified, and that can be correlated with the different isoenzymes, which by this level its presence we can say that a particular disease is there or not. So, it can act as a biomarker. Another definition is that biomarker is a substance used as an indicator of the presence of material or biological origin or a physiological condition or a process, specifically a diagnostic indicator or predisposition to a medical condition. Try to understand, there are two different forms, because the perception of studying isoenzymes and enzyme is that how enzymes act as a early biomarker or biomarker for different diseases. So, to understand this you need to have a definition. That is why you are seeing the on the clinical lab, when some report comes you see the normal levels. If you see how much there is increase or decrease, is it within the normal range, and then you will take the clinical decision on the conditions. Otherwise you cannot take. That is why the role of different diagnostic test is important to come to a conclusion. So, in the 13th chapter I have given, because this slide I have just particularly taken from Basuvan's book, textbook of biochemistry by Dr. Basuvan. So, in 13th it has been given details. So, you read that thing. For this purpose only we can see what are the commonly used markers of the enzyme. They are cardiac markers may be classified, because important what are the different cardiac markers and how they are actually classified, because cardiac conditions are different ways. There may be there will be myocardial infarction, they will be coming with the different state of the disease for our diagnosis. So, it may be cardiac markers of myocardial infarction, it may be markers of risk prediction, very important. You have high cholesterol for long time, chance of myocardial infarction is there, but still you are not. So, risk prediction, how much you are in risk, and markers of myocardial stress or CCF, that is very common, congestive cardiac failure. So, three conditions are different, and with the increased burden of the cardiovascular disease in throughout the world in India, this is a very important aspect you should know, and you should note it down. So, commonly used biomarkers for early detection of acute myocardial infarction are cardiac troponins TNI and TNT, and creatine isoenzyme, that is CKMB. This CKMB is also called as CPK also, that is same creatine phosphokinase. If you see in the diagnostic our list, it is given as CPK, that is creatine phosphokinase, because creatine kinase is creatine phosphokinase only. MB is what is given, that is the fraction, muscle brain, MB fraction is checked. Okay. So, this is very important. The BNP is an useful indicator of congestive cardiac failure. CCF is different. So, when you do the BNP, when you do the D dimer, when you go for the troponins, that concept should be there from now onwards, so that when you see patients or you get a report or you get a clinical case history, you should understand which biomarker to apply. So, I have given you the definition of biomarker, I have given you the examples, and I have categorized for the one disease. So, this it will go for the different disease. So, what is happening? So, enzymes commonly used for diagnosis of liver disease, like heart I have given. So, now you go for the liver, that also are used normally. They are ALT, AST, ALP, NTP, that is nucleotide phosphatase, and GGT. 5 are most important for the liver disease. Okay. Enzymes I am telling you. Other things also can be measured, like total protein, bilirubin content and other things, but enzyme, these are main enzymes. So, these with the you should know the normal levels. Normal levels will be given at the end of any chapter, you can see the normal levels, and you should see if it is abnormality is there, what can be the condition, what is the state of the liver or the allied organs which is related to. These are the things you should note down. So, normal level of ALT for males is 13 to 35 units per liter, and for females is 10 to 30 units per liter. It varies according to the males and females. Very high values, that is 300 to 1000 units per liter, is seen in acute hepatitis. So, you understand, somebody coming with the symptoms or thing of the hepatitis, when you see the measurement, you can understand the thing. That is why how it comes as a biomarker. What is the role? Why are you studying isoenzymes? What is the role? So, to understand the level of enzyme interpret it with the clinical condition. That is the key summary. So, both ALT and AST levels are increased in liver disease, but ALT is always greater than AST. Now, liver disease comes means there will be again divisions, that comes chronic liver disease, then you comes alcoholic liver disease and non-alcoholic fatty liver disease and other thing. Non-alcoholic fatty liver disease is now also changed to MASLD or metabolism associated steatotic liver diseases. That is because now all the things are also clubbed under the metabolic syndrome and metabolic associated diseases. Rise in ALT levels may be noticed several days before clinical signs of jaundice or manifestation. So, if you have some symptoms of jaundice like bilirubin level and other thing, before the bilirubin level rises, these enzymes can give you an indication it is manifested. So, if you have something you come to know you are feeling some uneasiness or some symptoms is there, if you go to the clinician, if you give the test, if you recommend that you do this test and bring, you can find that this level is high. So, that will give you a prediction that you have a, you are going to the state of jaundice because that thing will be high. Moderate increase, that is 50 to 100 unit per liter of ALT may be seen in chronic liver disease such as cirrhosis, write it down, this is very important, hepatitis C and non-alcoholic steatohepatitis or NASH. That is why I am telling, see the same enzyme with the different levels independently gives the prediction of a particular disease with its clinical features, provided you get the results from the laboratory properly correct. Understood?
Yes.
Agree with me? Half are sleeping in the class. I do not know what they have taken, most are sleeping. So, one particular example, try to understand one example you understand, then you can go for any other enzyme in the same way, but write it down these levels.
In acute it is more increased and in chronic it is less increased.
एक्यूट में सडन होता है तो इंक्रीज ज़्यादा होता है, सेल्स का ज़्यादा रहता है. क्रॉनिक तो एक टाइप पे जहाँ सैचुरेशन हो जाता है चीज़ें. क्रॉनिक मीन्स लॉन्ग टर्म ऑलवेज. एक्यूट मीन्स सडन थिंग विल बिकम. Acute disease and chronic disease, that is why thing. Acute disease you monitor, you give the thing, cure. Chronic long term medication to keep the levels within normal, because you know chronic means long things will not be cured at a short time. So, you keep something to that the level does not increase and you stay healthy over there. So, what are the acute disease, acute conditions you should know, and what are chronic condition, chronic disease. Then you can go for the treatment module.
Acute is like jaundice.
It is jaundice because chronic means what, long term. Like if you have fatty liver and stay grade 2, you can go to grade 3 or you stay at grade 2. These are chronic. So, you have to get lifestyle modifications, diet, exercise and other things. Try to understand, these are acute and chronic. Viral, all the things, acute condition. Fever, you get the infection 2 or 3 days, severe thing you get weak and get cured and go. But bacterial another, long term it goes like that, treatment. Reference level of the AST ranges from 80 to 20. It is a marker of liver injury and show moderate increase in the moderate to drastic increase in parenchymal liver disease, hepatitis and malignancy of liver, liver cancers, hepatocellular cancer, important marker. Yes. AST other name is? AST otherwise it is previously it was called SGOT or SGPT? SGOT. You should know these things. AST was used as a before. If you see the previous edition of many books, it will see that AST was used as a marker of myocardial infarction. That is in the olden days. Olden days means just some decades back it was used. The level is significantly elevated in myocardial infarction, but AST is also raised in various other conditions. So, troponins have replaced AST as a diagnostic marker in ischemic heart disease. AST is now used only as a marker of hepatic injury. That is the problem. That is the thing, is that it should be specifically targeting particular organ. If it overlaps or if it has a significant role in two organs at the same time, then it is very, then you cannot take any decision. So, if you do the test, wastage of money, and not only that thing, wastage of a clinical decision. It takes time, again you have to do for a specific marker to get the conclusive evidence. And this type of condition like myocardial infarction or congestive cardiac are critical condition. There is very less time to take decision. You cannot go for experimentation. So, you need specific markers to the specific organ at a specific time. There comes the role of a specific biomarker which we are discussing for a long time. ALP hydrolyzes aliphatic aromatic or thing, it is constituent. It is actually produced by osteoblast of bone associated with the calcification process. Moderate increase in ALP, ALP is also a thing, it is also hepatic, but one of the proportion of the ALP increase is also for the bone because it has an isoenzyme. Hepatic, it will be 2 to 3 times it is increased in hepatic disease, that is in infective hepatitis, alcoholic hepatitis, hepatocellular carcinoma. For very high ALP, 10 to 12 times the normal will may be seen in extrahepatic obstructions, that is obstructive jaundice caused by gallstone. You write it down, ALP different levels, important. Or by the pressure of bile duct by carcinoma at the head of pancreas. Intrahepatic cholestasis may be due to the virus infected hepatitis or by different drugs, that also happen. ALP is actually produced by the epithelial cells of the biliary caniculi and obstruction of bile with the epithelial things, and drastically increase in ALP. 10 to 25 signs are seen in Paget's disease or osteoblastic activity in enhancements in osteoblastic deformance, rickets, osteomalacia, osteoblastoma and metastatic carcinoma of bone. So, a single ALP with the level, proper level, you can distinguish between liver disease and the bone diseases, osteocarcinoma. But again I am telling you the interpretation should be okay. The levels what is coming from the lab should be reliable enough to come to a conclusive decision, otherwise your clinical decision will be getting stuck at that particular place. So, I have given example of LDH, CK, AST, ALP. Alpha 1 ALP moves in the alpha 1 position, it is synthesized by the epithelial cells of the biliary caniculi. It is about 10% of total activity and is increased in obstructive jaundice. Whereas alpha 2 part of the ALP, that ALP different isoenzymes as there I told you, it is heat labile and is stable at 56 degree centigrade, but loses activity when kept at 65 degree centigrade for 30 minutes. It is produced by the hepatic cells. So, when it gets denatured, what is its role? What is the indication, which type of cells it activates or affects, and what is the condition, clinical conditions for treatment. So, alpha 2 actually you see the heat stable one, actually it is inhibited by phenylalanine. It is found in normal pregnancy, that is why, and placental form isoenzyme closely resemble the placental is characteristic seen in circulation of 15% of the carcinoma lung, gut and liver, and is known as Regan isoenzyme or carcinoplacental enzyme. Another, it is a marker for different carcinomas. Carcinoplacental enzyme or the person who discovered the name the Regan isoenzyme. So, you see a particular enzyme with its different isoforms is playing a role normal condition and different abnormal conditions, which involves not only a single organ, but different organ. That is the importance of an isoenzymes as a biomarker. Pre-beta ALP is of bone origin and is elevated. Levels are seen in bone diseases. This is heat labile isoenzyme, that is BAP. Bone alkaline phosphate, sometimes it is called BAP or BALP also it is called, bone alkaline, that is biomarker. It is a biomarker bone disease. You see from the orthopedics they write this as a biomarker. Bone alkaline phosphatase, what is the role? Osteoblast and other activity. So, it not be always malignant condition, it may be a chronic condition or something diseases. So, that can it be used as a marker, but depending upon the level and the condition. GGT, you know, reference level is GGT is 10 to 30 units per and it is moderately increase in infective hepatitis and prostate cancer, but GGT is specifically used for clinically and specifically for alcohol abuse, because GGT is increase in alcoholics even on the other level. If you see the other liver function test is normal, but after in the alcoholics it is seen normally seen in the higher level, and it is rapidly decreased within few days when a person stops taking alcohol. Increase in GGT is generally proportional to the amount of alcohol intake. So, this is a direct marker of alcohol intake which progress to alcohol liver disease and alcoholics. Alcoholism is a chronic problem. So, GGT is a specifically marker for alcoholism and alcoholics. Reference level, or the reference level is very important, because only you know the reference level or limit or normal levels, then only you can go for interpreter, then you know the abnormal. If you do not know the normal, then it is no use of interpreting anything, everything is difficult for you then, understood. You should know the normal levels, then you go for the abnormal limit. PSA is produced by the secretory epithelium of the prostate gland and in liquefaction of seminal it is coagulum, it is a serum protease generally. PSA, you know, PSA is meant the prostate cancer, also it is being checked in the old age due to other condition like BPH, that is benign prostatic hypertrophy, or any problem with the prostate gland. In blood, it is bound to alpha 2 macroglobulin and alpha 1 antitrypsin, a very small fraction is free form. Reference serum value is 1 to 5 units per liter. It is very specific for prostate activity. Values above 10 is indicative of prostate cancer. 5 to 7 or 8 are seen in different prostate problems, but above 10 means chance of prostate cancer. You can see with the biopsy in our urology also, this is coming as a test for the prostate cancer, PSA. Prostate specific antigen. So, you should know the normal level and what happens in the case of prostate cancer. So, each specific enzyme I am going, because isoenzyme itself is a huge topic, specific enzyme, action in the body, role, normal limit, abnormal limit, conditions, biomarker. So, that summary you should be making note in that way. As I am showing you the way, the pattern I am following over there, if you remember in that way, it is easy for you to write in the exam. What are the competency you should know, what are the specific things you require, the basic structure you get, then you can fill the different forms and elaborate in your note. Acid phosphatase is also there. This is also seen sometimes in the prostate cancer, ACP. ACP is also used as a tumor marker. Since blood cells contain excess content ACP, care must be taken to prevent hemolysis while taking blood from the patient. Taking blood from the patient, there should be also there, because it goes for the process of hemolysis. ACP is an important, it is used in prostate cancer. Reference level of ACP is 2.5 to 12 units per liter. It is secreted by prostate cells, RBCs, platelets and WBCs, all related to the hematogram or the hematological profiles. Next comes acetylcholine esterase or SCH. It is only mainly on difference on the acetylcholine esterase term you can understand from the dependent on the acetylcholine. It is present in the nerve endings in the RBCs. Newly formed RBC will have high levels of CHE, which is slowly reduced according to age of the cell. Therefore, cholinesterase levels in the blood will be proportional to the reticulocyte count. You agree with me, because it would, yes, earlier another thing, it will be proportional to the reticulocyte count. Parathoin is an organophosphorus insecticide. Very problem of parathoin poisoning is there in many parts of India due to these pesticides things. It inhibits the cholinesterase in RBCs, is useful to determine the exposure person working with insecticides. These cholinesterase levels with persons or farmers which are working with different insecticides we give in the field, you can get an indication of the toxicity levels of these things. So, not only in the different chronic diseases, in very different which causes different toxicity to the blood or the organs, can also be determined to the different enzymes. HMP shunt, already you know there is glutathione will be there. So, drug induced hemolytic anemia, the G6PD deficiency is there, fava beans and how actually is with there. So, In G6PD deficient individuals, RBC lifespan will be reduced, but there will be no disease manifestation, you know, and there are particular places where you get this G6PD deficiency is there, or the gene that is forming the thing will be affected. But certain drugs like aspirin, mepocrine, primaquine and sulfa taken by such individuals, then there will be sudden damage in the RBCs. So, drug induced damage in the RBCs can also occur. So, primaquine what will be there? It stimulates the peroxide formation. In G6PD deficient cells, the level of NADPH is low, leading to unchecked buildup of the peroxides, resulting in the premature cell lysis, because the peroxide will actually, which inside the cells cannot stay in a stable state, it breaks down to H2 and O, which actually goes for the lysis of the cells. So, this what happens is that it goes for the cell lysis or the breakdown of the cells. So, the drug induced hemolytic anemia is a characteristic of G6PD deficiency. Fava beans, that is star beans, corner beans may be induced hemolytic anemia, which is called fabisim. Fabisim is a particular disease that is formed by these beans, which fabisim is a very common thing that is happening. So, what is G6 role of G6PD? What is the how hemolytic anemia is caused? What are the role of the different fava beans you take in the disease of fabisim? G6PD deficiency in hemolytic anemia, G6PD is occurring in which condition and which type of population or where it is present, that you should know. So, the gene the G6PD is located on in X chromosome, therefore, males and homozygous females will manifest as disease, while heterozygous females are carriers. X chromosome means you understand the genetic thing. So, who will be the carriers and who will have the disease condition, you should know. Yes.
So the power B can cause this hemolytic anemia in normal person only, normal persons or persons with GDP deficiency?
Fava beans induce hemolytic anemia is called fabisim, where there will be deficiency of the things, there will be causes the thing, because you take different types of beans normally, no, then you will be not taking any of the beans like that. In heterozygous condition where one gene is abnormal and another allelic is normal, the G6PD level in the RBC is half the normal value. G6PD deficiency seems to protect the person from falciparum malaria. Why it protects from falciparum malaria? Because the malaria parasite, yes, the RBC is not in the proper way, so that cannot harbor. So, they are safe from particular type of disease. So, tropical country is something, somebody is there and they have this thing, so they will have this thing. With tropical countries, the rate of malaria person having this thing is more. So, just G6PD deficiency has a selective advantage in malaria infested region, that is called the selective advantage. So, relation of malarial parasite with G6PD deficiency. Methemoglobinemia, NADPH is also necessary for reduction of methemoglobin, oxidized form to hemoglobin. Hence, in G6PD deficiency individual, methemoglobin may be also manifested. But the most important is how malarial parasite cannot reside in the G6PD deficient individuals. Partially it is good. So, in tropical countries we will be having where the proportion of malaria and other things are more. So, that will be a selective advantage. So, something which is happening inside the body can have an advantage, because they are the malarial parasite or other things from the outside cannot reside inside, come inside the body or reside in the body for for long time. Next comes the enzyme starts to, that is pancreatitis, that is amylase. The value is increased about 100 times in case of that is acute pancreatitis, is a amylase, which is life threatening condition. Peak values are seen in between 5 to 12 hours of the onset of disease and returns to normal after within 2 to 4 days of the acute phase of subside. Amylase and lipase are the two markers for pancreatitis. I will come to the summary of all the different enzymes. Reference value of amylase in urine is less than 375 units per liter. It is increased in acute pancreatitis and increased on the first day and remains elevated for 7 to 10 days. That is important. So, pancreatitis symptoms is a pain, severe, other things, goes to the some clinician, you get an elevated amylase for long time, you can understand there is a chance of pancreatitis. But amylase with lipase is important for the diagnosis of the pancreatitis. it will hydrolyze the triglyceride to beta monoglyceride and fatty acid. The enzyme is in the pancreas enzyme. The level of blood is elevated in acute pancreatitis. This persists for 7 to that I have given you. Thus, lipase remains elevated longer than amylase. Moreover, lipase is not increased in mumps. Therefore, lipase estimation is over at a good advantage over amylase, because again I am told you same enzyme, it is acting in two different places, cannot be a specific marker for a particular disease. So, lipase with amylase is a marker for pancreatitis. Lipase alone, amylase alone cannot do that, because it is used in mumps. You know the mumps, that is particular thing that happens. Yes, swelling of the glands. It is moderately increased in carcinoma pancreas, biliary disease, and perforating peptic ulcers. Perforating peptic ulcers means ulcers where, yes, perforations, or simple language, pores or something is there, leaking something, that is the thing. But mainly these two are for neuron specific analysis in neural disease and epidermolysis. NS is a tumor marker for neuroendocrine, small lung cell cancer, neuroblastoma, pheochromocytoma, medullary carcinoma, thyroid. Along this tumor marker, you have the one more thing is that VMA for neuroblastoma and pheochromocytoma. When amino acid metabolism will be taught, in that thing you will come. What is the role of VMA or vanillyl mandelic acid? That also is a good marker for pheochromocytoma and neuroblastoma. So, these are the different enzymes, acetylcholinesterase, peroxidase. So, now I will just sum up the things you should know. What are in hepatitis? This is a summary of what you have learned in this 45 minutes class. That is this. Hepatic disease is the alanine aminotransferase, marked increase in parenchymal the liver diseases. Aspartate aminotransferase also elevated in parenchymal liver disease, but different condition, different stages is there. Alkaline phosphatase, gamma glutamine transferase. In myocardial infarction, we have learned about the cardiac troponin creatine kinase. We have ruled out the role of AST and LDH, which is non-sensitivity. Muscle disease, we have creatine kinase, aspartate aminotransferase and aldolase, earliest enzyme to rise but not specific. Bone disease, we have alkaline phosphatase, marked elevation in rickets and Paget's disease. Prostate cancer, that is PSA and ACP. Pancreatitis is amylase, lipase. Streptokinase, a urokinase, streptokinase that is from streptococcus, urokinase from urine can lyse the intravascular clots and therefore used in myocardial infarction. When there is infarction, there will be a clot which is lysing. Immediately, if you can give the streptolysin of the urokinase, the chance of survival of the patient depending on the condition is always more. Pepsin and trypsin are given to patient with defective digestion. How you know that is given? You get all the thing prescribed by the physician. You take this enzyme and other things. It's pepsin and trypsin for the digestion. You are having lot of problems due to digestion related issues, then you give this pepsin and trypsin. Asparaginase is used as an anti-cancer drug. So, this is what are the different enzymes and what are the therapeutic application. Important question. Therapeutic applications of different enzymes, because that is why you are studying the isoenzyme. Therapeutic application. It is a biomarker, predictive marker, prognosis, risk management, risk assessment, all things will come under this. So, this chart is very, very important. Write it down. Picture to khich de, that is okay. I want that it should be replicated in your notes also. So, that I will be happy to see all the 125% answering the question in a proper way. Understood? And which are used for testing. One is therapeutic applications and one is which for testing. Urease, urea, uricase, uric acid, glucose oxidase glucose, peroxidase glucose cholesterol, hexokinase glucose, cholesterol oxidase is for cholesterol, lipase is triglyceride, HRP both by ELISA technique, enzyme linked immunosorbent assay. Alkaline phosphatase also ELISA technique. Restriction endonuclease by southern blot and RFLP full form is restriction fragment length polymorphism. Reverse transcription Taq polymerase is by the PCR. Now, applications of enzyme therapy. What do you understand? What are the different applications? This is the new concept of enzymatic application of therapy. What is enzyme therapy problems and what are its solutions? That you should know. This is the advanced part. Enzyme therapy is very good. We can go, we can give the thing, you are prescribing, but what are the problems and the solutions? Problems may be immunogenicity. Immunogenicity means immune reaction, because these are proteins in nature. Immunogenic means it will act on the body system. So, how it responds to the body is one of the problem. Short in vivo half life. All enzymes will have a half life for this activity have its maximum, then slowly subside down. So, that short half life you cannot increase, but you have to apply in such a way that within the short half life this action is being monitored for the therapeutic advance. And lack of target specificity. Lack of target specificity will be where you are giving the enzyme. It may have it may act on different organs at the same time. Then the target will not be. It is very difficult. You cannot give organ to organ. You will find the organ and you give intervention. It is not possible. So, that target where you give, because if it is not precise, if it is very generalized, it has in different parts it is found. Then the target, that is the specificity of the target, is not found, or it is not able to demonstrate it. So, what are the solution? You should know this thing. This is not given in any of the books. This I have made the slide for the recent. What are the things, advanced research that is being there, that what are the advantage of this therapy and what is drawbacks. Immunoresponsive monitoring, that how actually the person ever giving the thing is immune response. Are there any reactions that is occurring, any hypersensitivity reactions, any cross reactions? If any response is there, anything which is happening to the innate and the adaptive immunity is there, that can be taken down. Then comes the molecular modifications, encapsulation, encapsulating and giving so that it goes to the target and leave it. And last is targeting by nanoconjugate, nanoparticles and precisely. So, these are the problems and the solutions what you should be going for enzyme therapy. So, what is enzyme therapy? Its challenges, problems and your solutions, because you have to see the solutions. Problems will be there, more advanced thing will go in therapeutics, more challenging things will come, but we should come out with a proper solution. So, that will help to the diagnostic efficacy and patient and therapeutics for the patient. Thank you. ये नोट ले लो, आप तो कम से कम नींद से खुल जाओ कुछ चीज़ों को.